First, I would like to thank the organizers for inviting me to give this presentation. It's great to be in Canada and in Toronto. My last time in Toronto was 21 years ago, so it was time to come back. So I have no conflicts of interest, and I'm an employee of the University of Eastern Finland and Kuopio University Hospital. So first, few words about the recommendations for diabetic patients regarding dietary fat. So several recommendations, they are very consistent regarding the quality of dietary fat, so that the proportion of saturated fat should be decreased. But regarding the proportion of energy nutrients, there's flexibility. And the recommendations of the American Diabetes Association and the British and Swedish recommendations state that there are many studies with methodological unsoundness, so it is difficult to draw conclusions regarding the optimal proportion of energy nutrients. The Canadian recommendations recommend the proportion of fat to be 20 to 35% of energy intake, and they specifically state that carbohydrates can comprise up to 60% of energy intake when low GI carbohydrate sources are mainly used. So for diabetic patients, individual goals regarding the proportion of energy nutrients can be set as long as the quality of dietary fat and carbohydrates is taken carefully into consideration. Before I go to the dietary patterns, I would like to present you a few things about the systematic literature review that we performed for the Nordic nutrition recommendations about 2 years ago. So we had 4 research questions, and as you see here, glucose and insulin concentrations as well as type 2 diabetes risk was included as an endpoint or outcomes in these research questions. Regarding insulin sensitivity and serum or plasma insulin concentrations, we found that those diets that were enriched in monounsaturated fat compared to saturated fat, they increased insulin sensitivity measured by insulin sensitivity index or HOMA-IR, and the strength of the level of strength of evidence was considered as probable. And the same goes with fasting plasma or serum insulin concentrations. Regarding type 2 diabetes risk, it was found that polyunsaturated fat or linoleic acid itself, as compared to carbohydrates or saturated fat, has an inverse association with type 2 diabetes risk, and the level of evidence was considered as probable. Regarding long-chain omega-3 polyunsaturated fatty acids, the conclusion was unlikely, and this needs more specific attention. So when we look at those studies, when the subjects had gotten mainly the long-chain omega-3 fatty acids from fish oil supplements, there were studies which showed even increased risk of type 2 diabetes. But when these fatty acids were received from fish, so the subjects had been eaten fish, then there was no increased risk, and actually in some studies there was protection against type 2 diabetes. So we have to take into consideration the source of long-chain omega-3 fatty acids. And regarding biomarkers, it was shown that in plasma phospholipids and cholesterol esters, linoleic acid had an inverse association with type 2 diabetes. The level of evidence was suggestive, and saturated fatty acids in phospholipids and cholesterol esters had a positive association with type 2 diabetes with the same strength of evidence. And then I move on to the dietary patterns, and we have heard about Mediterranean and healthy Nordic diet patterns this morning. I have few slides are the same as we have seen earlier this morning, and then I have a few slides regarding the DASH diet, so dietary approaches to stop hypertension. All of these dietary patterns emphasize the quality of dietary fat, so the intake of saturated fat should be decreased and the intake of unsaturated fat should be increased. So here you see the systematic review of Shirani and co-workers regarding the effects of DASH diet on risk for developing type 2 diabetes. And they found that there was a reduced fasting insulin concentration, especially in those studies that lasted for more than 16 weeks. And here you see the results of the fasting insulin concentration. So especially those who had metabolic syndrome or dyslipidemia, they had protection. But those who didn't have any metabolic syndrome or dyslipidemia, they didn't benefit of the DASH diet regarding fasting insulin concentration. Regarding fasting glucose concentration, there was no effect. And there was no effect on HOMA-IR either. And then there are 3 studies regarding DASH and gestational diabetes. In this study, they have 52 women. This was a randomized controlled trial, and the subjects were randomly assigned either to a DASH diet or a control diet for 40 weeks during the gestational weeks of 24 to 28. And the diets prescribed for the intervention group was following very strictly the principles of the DASH diet. So it was rich in fruits, vegetables, whole grains, and low-fat dairy products. And it had low amounts of saturated fat, cholesterol, and refined grains. And the total intake of sodium corresponded to about 6 grams of salt per day. In the intervention group, there were less cesarean sections, lower percentage of the mothers needed insulin therapy, and there was lower birth weight. And there was no effect on birth length or APGAR score. And in 2 other studies, the design was very similar. And in the first study, they found decreases in fasting plasma glucose, insulin, and HOMA-IR. And in the other study, they didn't actually find a difference in fasting plasma glucose. It was on borderline significance. But they performed an OGTT, and they found decreases in plasma glucose concentrations at 60, 120, and 180 minutes. Also decreases in HbA1c and total cholesterol, LDL cholesterol, total to HDL cholesterol ratio, and total triglycerides and systolic blood pressure were found. Regarding the Mediterranean diet, by a very recent systematic review by Sleiman and co-workers, they stated that most of the studies showed favorable effects of the Mediterranean diet on glycemic control and cardiovascular diseases, although a certain degree of controversy remains regarding some issues such as obesity. And in the Molisani study, the Mediterranean diet, the effect of Mediterranean diet was studied on mortality in subjects with type 2 diabetes, and they had about 2,000 subjects. This was a prospective cohort study with a median follow-up time of 4 years, and they found that the traditional Mediterranean diet associated with reduced risk of both total and cardiovascular mortality in diabetic subjects. But this was independent of the severity of the disease. They, for example, look at those subjects who had frequent hypoglycemia or so, and there was no difference between the groups. The major contributions in the diet were offered by moderate alcohol intake, high consumption of cereals, fruits, and nuts, and reduced intake of dairy and meat products. And this figure you saw earlier today, so this was about the Predimed Roy study with 418 subjects with 4-year follow-up. And with these 3 groups, so the Mediterranean diet group, subjects in the Mediterranean diet group had much less type 2 diabetes than in the group that was actually called low fat in the study, but it had 40% of energy intake as fat, whereas the other groups had 41%. So maybe this low fat is not that an appropriate term to describe this diet. And as it was pointed out earlier today, there was no change in body weight and physical activity. And Ulf presented this healthy Nordic diet very thoroughly. I just would like to remind that there was a very nice result regarding plasma insulin concentration in addition to serum lipid profile and body weight and systolic blood pressure. Ulf was talking about the CIS diet study. I'm not talking about that, but in Kuopio we performed a system study, which was actually a pre-study for the CIS diet study. And we had 3 groups there. The systemet group had low insulin response grain products, fatty fish 3 times per week, and bilberries daily. And the healthy grain group had low insulin response grain products, and the control group had high insulin response grain products. They were prohibited of eating bilberries, and they were instructed to consume only 1 fish meal per week. And what we found was that in the systemet group, all 2-hour glucose area under the curve during the OGT of glucose, insulinogenic index and disposition index, they all improved in the systemet group. And the 2-hour glucose improved also in the health grain group. And then, as Ulf pointed out, the diabetes prevention studies actually it very thoroughly follow the principles of a healthy Nordic diet, because it was performed at my department, and I know exactly how the subjects were instructed. But no one talked at that time. This was launched in '93. No one talked at that time healthy Nordic diet. So, but I think we can consider this as a study applying principles of healthy Nordic diet. So there was weight loss in obese subjects. If you went obese, you didn't need to lose weight. And then there were these 3 goals regarding diet. So dietary fat was supposed to be around 30% of energy, saturated fat below 10% of energy, and dietary fiber 15 grams per 1,000 kilocalories, and physical activity at least or more than 4 hours per week. And here you see the results that you have seen actually, I think, many times before. But this is very impressive that in the intervention group, this is 15-year follow-up now, the difference between the groups regarding type 2 diabetes incidence remains. And here you see the type 2 diabetes incidence according to the goals reached at 3 years when the intervention was actually stopped, because the ethical group thought that the difference between the groups is so big that it's unethical to continue the intervention. But you've seen that the more goals you achieved, the less was your type 2 diabetes risk. And then here at the end of my presentation, a few words about inflammation, which is very significant factor behind hyperglycemia, affecting liver by increasing glucose production, affecting pancreas by decreasing insulin secretion, and affecting muscle and adipose tissues by decreasing insulin sensitivity. The arrow there is hidden. And Odegaard and Chavla have presented this summary that increased proportion of saturated fatty acids in serum, they cause cellular stress, which is associated with insulin resistance. There also seems to be direct effect on insulin resistance as tissue inflammation, and via increased serum glucose concentration, there will be frank metabolic diseases and clinical consequences. So inflammation is very important behind hypoglycemia and impaired glucose metabolism, and serum saturated fatty acids seem to be one big issue behind this phenomenon. And here you see results from the National Institute for Health and Welfare, Helsinki, Finland. This group actually, they call the healthy Nordic diet as the Baltic Sea diet, but this is exactly the same. And in the DILCOM study, they cross-sectionally assessed the inflammatory markers related to obesity and the Baltic Sea diet score. So the higher score you had, the more components of the healthy Nordic diet you had, the lower was your high-sensitive CRP level. So to conclude, there's flexibility in the proportion of energy nutrients regarding glucose metabolism and diets for type 2 diabetes, but we have to strictly keep in mind that we have to pay attention both the quality of dietary fat and the quality of carbohydrates. This is extremely important. And the dietary patterns rich in healthy oils are beneficial for both prevention and treatment of diabetes. Thank you.
As you can see, the topic of my presentation is dairy and diabetes, and we've already heard some very passionate discussion this morning about dairy, and so the timing of my talk is hopefully advantageous to shed some additional light on this issue. In terms of my conflicts of interest, I do receive some funding from Dairy Farmers of Canada, who are a supporter of this conference. I also receive funding from a number of other agencies, including the CIHR, the Canadian Diabetes Association, Canada Research Chairs Program, U of T Banning and Best Diabetes Center, in addition to the Dairy Farmers funding, which in part comes from Agriculture and Agri-Foods Canada. I'm also a grant reviewer for Dairy Farmers. And in terms of mitigating bias, I guess I can say that the Dairy Farmers funding is investigator-initiated, peer-reviewed, and they don't have any role in the analysis or interpretation of the data. And it really represents a portion of my total funding. So here's the outline for the talk today. I guess maybe the additional disclosure I have is that I'm an epidemiologist, not a trialist, although I have done some trial work. And so a lot of what I'll show you today are from the observational literature. We'll touch on some dietary patterns work. That's the topic of this particular symposium. We'll look at some evidence from trials. And then I want to touch on some potential mechanisms and biomarkers, and I've put those two together because I think at this stage in the dairy literature we really don't know whether we have biomarkers or bioactives, and I'll touch on that a little bit, specifically focusing on fatty acids, which again is advantageous given the discussion this morning, or hopefully advantageous. So in Canada, our recommendations for dairy are 2 to 3 servings per day, and really we're not meeting that by any means. You can see this figure from our National Health Survey showing the percentage below the recommended number of dairy servings. The problem is widespread in age and gender groups, particularly in girls, 10 to 16, and in older adults. We saw from Dr. Bernard's talk this morning trends in cheese consumption from USDA data. This is the accompanying slide for milk, beverage milk, and we can see since 1970 there's been a decline in total beverage milk, a decline in consumption of whole milk, and kind of a leveling off since 1990 in low-fat milk. And so this underconsumption is potentially a problem given that dairy products are rich in a number of macro and micronutrients that potentially have benefits in maintaining health and preventing chronic disease. We've heard a lot over the years about bone health, but increasingly we're seeing literature that's focusing on other chronic diseases, including cardiovascular disease and type 2 diabetes. And so what do we know about dairy consumption and type 2 diabetes from observational studies? And so over the past 5 or so years, we've had about 5 meta-analyses of prospective cohort studies assessing this question. What does dairy intake do in the context of type 2 diabetes? And so I'm showing you only 3 of these for the sake of time, but the meta-analyses by Tong and Ayun, looking at total dairy consumption, reported in their summary relative risks that total dairy consumption was inversely related to the incidence of type 2 diabetes. Recently, we've had a new meta-analysis from Chen and colleagues, which does not report the same finding. And I'll point out to you that the studies included in these metas are all different. Some of it is there's overlap, but there's not pure overlap. Some of this is related to new studies being introduced and added to updated meta-analyses, but there are other selection factors that determine whether studies get in or not. It's interesting, in the Chen paper we see the inclusion of 3 updated prospective analyses out to 10 years from the 3 Harvard cohorts, the Health Professionals Follow-Up Study and the Nurses' Health Studies 1 and 2. Now, what's also been interesting in this kind of quickly moving literature on dairy in the observational world is the question of dairy subtypes. And again, that's a little bit of a moving target as well. We can see from the Tong paper that low-fat dairy and yogurt were associated with reduced risk of incident type diabetes. From the Ayun paper, a little bit more recent, the story is a little different. Low-fat, they found a similar finding, reduced risk of incident diabetes. Not yogurt, but cheese was related to lower risk of incident diabetes, and no relationship for high fat or milk. And then in the most recent meta from Chen and colleagues, again, the only dairy subtype which was related to lower risk was yogurt, and all the other findings of the subtypes were null. So some of the work that I do involves the underlying disorders of type 2 diabetes, and I think all of you as diabetes researchers will appreciate that once diabetes has been diagnosed using glucose criteria, metabolically the horse has been out of the barn for some time. And I'm referring to this idea that diabetes emerges because of chronic, long-standing, insidious disorders of insulin resistance in several tissues, including the liver, the muscle, and the adipose tissue. And then increasingly, we're appreciating the importance of beta cell dysfunction as a primary underlying disorder in the etiology of type 2 diabetes. The GWAS literature is telling us about the importance of beta cell genes in diabetes etiology. Some of you who may have been at the ADA will have seen Dr. Venkat Narayan's talk, Kelly West's talk on impaired fasting glucose in India. So I think to understand any risk factor in the etiology of diabetes, it's also important to understand what's going on with the underlying disorders. It's also important to measure those disorders properly. And so by that I mean use the best measure that you can in your study given all of the limitations that we face with logistics and funding and patient burden, et cetera. Validated, detailed measures as much as possible. And in particular, when we measure beta cell dysfunction, it's important to keep this concept in mind. And again, as a diabetes audience, you would have seen this figure before, showing the compensatory relationship between insulin sensitivity and insulin secretion, sometimes referred to as the disposition index concept from Richard Bergman. And basically, in a nutshell, this concept holds that as insulin sensitivity decreases with advancing age or adiposity or declining physical activity, in normal physiology, we see a compensatory response from the beta cells that maintains normal glycemia. Herzl Gerstein's going to come and talk to us in a couple of days, and he's got a great paper telling us how the system works really hard to maintain tight glucose levels, and this is one of the mechanisms of that. However, when beta cell dysfunction starts to emerge, either due to genetics, intrauterine factors, exogenous factors, that compensation becomes disordered and hyperglycemia eventually develops. The risk of using the wrong measure here is that you can misinterpret an insulin secretion measure if it's looked at in the context outside of ambient insulin sensitivity. So what do we know from the observational literature on dairy and these underlying disorders? Again, the literature is quite mixed. Only one of these studies here from IRIS used a detailed measure. There was no association. And many of these studies have used HOMA, which is a validated measure, but again, a lot less detailed than some of the other measures we have available to us. And importantly, only one measure that looked at beta cell function using HOMA-B, which again, there's some question about the utility of this measure as a measure of beta cell function. Now, the topic of this session is dietary patterns, and so I've tried to be observant of the requirements that John and Cyril put on me about talking about dietary patterns. So I've got a couple of slides on that, and we've heard some of this morning, so I don't think I have to go into tremendous detail. Many of you will be aware that there are two general approaches to dietary pattern analysis, the so-called a priori approach, where we calculate graded scores that describe ideal diets according to existing scientific literature. And we've heard a lot this morning about the Alternative Healthy Eating Index, the Mediterranean diet, and DASH. The other way this is done is to use a posteriori approaches using multivariate statistical methods that take observed data, usually from food frequency questionnaires, and these methods include principal components analysis, reduced rank regression, and these give us patterns that come out from these particular approaches. Now again, we've heard a lot this morning about where dairy sits in these different dietary patterns, so I won't dwell on it in great detail. Suffice to say that for the a priori approaches, there is an allowance for low-fat dairy products in low to moderate amounts. And we've seen from previous talks how these dietary patterns are associated prospectively with the incidence of type 2 diabetes. I've got some references here of meta-analyses. You've heard some earlier this morning. What about the a posteriori approaches? It's a little bit more complicated, and those of you who've done factor analysis or PCA will recognize the art and the science in these methods. But really what we see is the emergence of 1 to 4 diet patterns, sometimes more. Usually there's a healthy or prudent diet pattern that emerges and an unhealthy or Western diet pattern, and these predict diabetes, as you might imagine. The way dairy loads on these patterns is a little bit complicated. If present, low-fat dairy products tend to load on the healthy pattern, although that doesn't always happen. And those of you that do these methods will recognize some of that relates to how heavy the loading is and how it gets interpreted, whereas high-fat diets tend to load on detrimental patterns that are predictive of diabetes. What do we know from trials? I'm not going to do this any great service because of lack of time, but what we can point out to you here is that there's a recent meta-analysis from Benatar and colleagues, and what they did was they meta-analyzed 20 studies, about 1,700 participants, median duration of 26 weeks. The mean increase in dairy was 3.6 servings per day, and what they found was that there was a significant increase in weight using both whole fat and low fat dairy, but no significant changes in these other parameters that we've been talking about this morning. Waist circumference, HOMA-IR, fasting glucose, CRP, lipids, and blood pressure. Now, I'm going to pull out the HOMA-IR figure for you just because it's relevant to what we're talking about this morning. And you can see here, it's probably at the back, it's tough to see, and I apologize for that. But for HOMA-IR, there was a very large and significant heterogeneity score. And hanging out with John, I have gradually been educated on how to interpret these meta-analyses parameters. And so really, all you have to do is look at the individual studies. We have 2 that were indicating significant reductions in HOMA-IR and 2 null studies. And so really, the jury is still out. More recent publications, there's a paper by Rideout and colleagues showing an 11% improvement in insulin resistance after 6 months of low-fat dairy, and then a very recent systematic review of 10 trials of dairy and HOMA really showing mixed results. So what do we have in terms of mechanisms and relevant biomarkers? And I told you kind of why I've mixed those two things together. Well, a number of components of dairy have or are currently being rigorously investigated in terms of their role in diabetes pathogenesis. Last year at the ADA, we had a lot of attention on vitamin D, and I think really we need to wait and see what those trials are saying, most notably D2D, PTAS's study. I'm going to focus on fatty acids for a moment because, as you've seen this morning, this is a quickly moving area, controversial. When it comes to the dairy fat, the fat profile of dairy, you can see it's very complex. Dairy contains trans, saturated, polyunsaturated, monounsaturated fatty acids. About 60 to 75% of those are saturates, and there are some naturally occurring trans fats. Now, we'll start with the biomarker story. These fatty acids have been used in some studies as biomarkers of dairy intake. And in epidemiology, we're challenged by the measurement of diet on several levels. One of the biggest issues is that our most commonly used instrument, the Food Frequency Questionnaire, is subject to misclassification of intake, which tends to dilute effect estimates, and thus gives you the mixed literature that we see in nutrition in general. Biomarkers are thought to help to overcome some of those problems, and these fatty acids have been looked at in the literature as potentially useful biomarkers of dairy intake. They meet the criteria of utility in that they are from exogenous sources, and they've been validated in various media as potentially useful markers of intake. Are these merely biomarkers, or are they bioactive? And again, this is controversial, very, very quickly moving literature right now. Some fatty acids have been intensively studied, and many of you will be familiar with the CLA literature. A lot of this is isomer specific. The naturally occurring CLA isomer is the 911 form, which comes from ruminant sources, and there are some potentially beneficial mechanisms have been described, including increases in GLUT4 and insulin receptor expression, reduction in macrophage infiltration, and the downregulation of inflammatory markers in adipose tissue, and activation of PPAR alpha. Again, this literature is complicated because the other major form, the 1012 form, can sometimes have different effects. Vicenic acid, which is the precursor of 911 CLA, also has been studied in terms of its PPAR alpha and gamma activation. Then there are some other fatty acids that we're seeing more and more in the literature that we know less about. And so many of you will be familiar with Dariusz Morzafarian's studies showing that trans-palmitoleic acid, or trans-16-1N7, is inversely related to various outcomes, including type 2 diabetes. And they have speculated that this may be because this particular trans fatty acid mimics non-hepatic cis-16-1N7 in improving insulin resistance and suppressing DNL. And then another sort of set, the odd chains, which are shown in some recent meta-analyses where the saturates have been broken down, have been standing out as not behaving like the traditional saturates, such as palmitic acid, and that they have been protective, quote unquote. Is that because they're merely markers of dairy intake or because they're bioactive? We don't know the answer to that. Ingrid Santorum, who works in my group, has been digging around, and really there's not much there as far as we can tell on mechanism. There's one study we've cited here that looks at accumulation in adipose tissue. So what do we know about the circulating fatty acids and outcomes? Again, the literature is quite mixed. I'll just point out that the red text indicates significant results. We've maintained the direction of the association for the non-significant results in black. And again, literature is quite mixed. Much of the literature focuses on type 2 diabetes as an outcome. We know less about insulin resistance and beta cell function with these fatty acids. And so that inspired us to take a look at this question using some data from the insulin resistance atherosclerosis study. And this was a paper led by Ingrid in my group that came out in AJCN last year. So IRIS is a prospective cohort study Baseline exam was in the early 90s with a 5-year follow-up. The unique thing about IRIS is that the participants were very, very richly characterized, including oral glucose tolerance tests, and everybody received a frequently sampled intravenous glucose tolerance test, which gives very detailed measures of insulin sensitivity, as well as beta cell dysfunction in the context of the disposition index. Fatty acids were measured using gas chromatography, and from that profile we were able to, that profile included 15O and trans 16-1N7, which we looked at in relation to incident diabetes at 5 years, as well as insulin sensitivity in the disposition index. So this is the figure from the logistic regression analysis, and you can see, so these are odds ratios and 95% confidence intervals with the unity line indicated here. And in the full cohort, we can see that with standard deviation increases in the concentration of 15O, there was a significant reduced risk of 5-year incident diabetes adjusted for confounders. We tested for interactions by gender, glucose tolerance status, and ethnicity, and there were no significant interactions, although you can see the point estimates do move a little bit in some cases. Effects seem to be stronger in normal glycemics and Hispanic Americans, although subgroup analysis in this cohort is underpowered. When we looked at the underlying disorders, we found that 15O was significantly related to, significantly positively associated with insulin sensitivity and disposition index, indicating better insulin sensitivity and better beta cell function. Now, in contrast, transpamidolaic acid was not related to either of these outcomes, nor was it related to incident diabetes. And we were sort of surprised by that, given that some of the papers had been coming out quite recently. So we looked at how these fatty acids related to self-reported dairy intake in the cohort from the FFQ. And 15O was quite significantly positively related to dairy intake in this cohort, while trans 16-1N7 was not. And in fact, it seemed to be picking up more of the intake of partially hydrogenated containing foods. All right, so discussion, this is just for this paper. 15O was a marker of dairy intake in this cohort, and it was related to insulin sensitivity, beta cell function, and lower risk of diabetes. That was not the case for transpamidolaic acid. Second last slide, future directions. This is just my opinion. I think we need more data on the roles of dairy subtypes and its components. We need to be careful when we characterize the underlying disorders of diabetes. As best you can, use detailed, validated measures of insulin resistance, beta cell function, possibly some of these other disorders that we know relate to diabetes. There was a session on insulin clearance at the ADA that some of you may have seen, and we've heard a little bit about inflammation. We also need to assess the full spectrum of dairy fatty acids in these studies, and that requires you to have a conversation with your favorite lipid biochemist, because there are some important methodological issues that are related to that, including the identification of the right standards, as well as the column, the right column to pick up that part of the fatty acid spectrum that contains many of these dairy fatty acids. Trials, again, careful consideration of dose, duration, dairy form, and content, as well as outcomes. Conclusions, I think total dairy in most meta-analyses is inversely related with type 2 diabetes incidence, although the most recent meta was not consistent with that, and we have inconsistencies with subtypes. Low-fat dairy is part of dietary patterns that inversely relate to diabetes risk. Trials have been inconsistent, but I think we have some work to do on design issues. What are the mechanisms? We don't know that exactly yet. A couple of intriguing avenues, particularly with fatty acids. Are these bioactives or biomarkers? More work's needed. And I just want to highlight Ingrid's work, AJCN paper, as well as Robin Glicksman, who's been doing diet patterns analysis in our group. Other members of my group, funders I've talked about, and this is the IRIS investigator team. Thank you very much.
Good morning, everyone. You know, I came from South Canada, from a small county called the United States, and a small tiny city called Boston. I don't have Bostonian accent, despite being in Boston for almost 20 years. Let me first say my disclosure here. Take your time to read it. But to mitigate this disclosure, I would like just to present only the data that published and peer-reviewed and presented in big conferences. So before I start, I would like to thank three people, John, Cyril, and David, for inviting me here. I had been in diabetes field for almost 34 years. And all my work had been on weight management and nutrition and lifestyle for people with diabetes. And to sum all my experience for all those years, I will do it in one single slide. And this slide is here. You know, the problem in diabetes, as you all know, is because of the increase in body weight. If you had been in the US, in Phoenix, Arizona, and some other places, there is a restaurant called Heart Attack Grill. They serve a lot of nice burger, one called single bypass burger, double bypass burger, triple bypass, quadruple bypass burger, which is like 7,000 calories with butter shaken and so on. So you can imagine where we are and how we are moving and how things are and so on. And we have been trying for years and years and years to see how we can solve this problem. Finally, we have very, very good solution that is no longer embargoed. It was presented 2 days ago in the American Diabetes Association, if you came in the first day. The data is from our Y-Weight program at Joslin. This is in real-world clinical practice. So this is not in very strict clinical trials. And you can see here, for the first time, we're able to show that people for 5 years in real-world clinical practice can maintain 6.4% weight loss. Not only that, more than 50%, 53% maintained 9% weight loss. We were honored this year that this study got the Michaela Moden Award as the best study for the year in prevention and management of diabetes. But the most interesting, in the same conference, we presented data to compare Y-Weight program for the first time to bariatric surgery. And interestingly, you can see with left band, there's some additional weight loss. But if you look to the A1C, after 1 year, it is exactly the same. Not only that, all the primary endpoints, second endpoints, which is resolution of diabetes or remission from diabetes, to be accurate, is exactly the same. In the Y-Weight, we were able to cut medication by 50 to 60%. We're able to have remission around 14% of people with diabetes. And we got the biggest fund from NIH now to develop this model for primary care physician across the entire United States. But the most interesting, if you look here and you look to the physical and mental components of the quality of life, and you can see with the Y-Weight programs, there is improvement at 10% weight loss after 1 year, marked improvement. And you can see very little improvement, no improvement with bariatric surgery, and by the end, slight improvement. On mental health, this is a big difference. You can see with a Y-Weight, marked improvement in mental, and you can see this the same at 1 year. You don't see any improvement in mental health with bariatric surgery. And there is many data to show even cost comparison between both. So this is an example of patient enrolled in the Y-Weight program, has diabetes for 17 years, managed on 2 oral medication, more than 100 units of insulin, A1C 7.3, and then you can see this patient after she lost weight and maintained that weight loss for 5 years, and the A1C now is in 6%, 0 medication, and diabetes remission for 6 years. Let me lead some discussion around what we did And I will get to the component as well of the meal replacement. This is a multidisciplinary program, so it is not dietary only or exercise only or education only or behavior modification only, but we add big component of change in even diabetes medication. So the major difference between look-ahead study, which I believe all of you had been aware with this study. I was one of the co-investigators in the look-ahead and diabetes prevention program in the US. What we did is that we fixed the caloric intake down for women around 1,500, men around 1,800. All of them, like the look-ahead, we give them 2 liquid meal replacement, this diabetes-specific meal replacement, 2 snacks, and transition to regular diet in week 10. But the most interesting is that the exercise component is 300 minutes per week in comparison to 175 minutes in the look-ahead, and here more strength exercise in comparison to just aerobic exercise. Dietary pattern is entirely different between both. In the look-ahead study, carbohydrates were 55%, protein was around 15%. In the Y-weight program, carbohydrates was no more than 40 to 45%, and glycemic index was low, and protein was a little bit higher. Went up to 1.5 to 2 grams per kilograms of the body weight. So let me remind you with very old theory. I'm not sure how valid this now, but this is how Eliot B. Joslin used to treat diabetes in 1923. And the diet Eliot Joslin was giving to his patients, it is very interesting, very eccentric diet. Just 10 grams of carbohydrates, only 2%, and 75% of the diet was from fat, and actually 1,800 calorie diet. And in his diet, he was able to cure every single case of type 2 diabetes. It was called fatty diabetes during that time. And he was also able to keep people with type 1 diabetes alive for 10 years. So how he was giving them butter and bacon and fat and all those kind of stuff, and was getting those people healthy. And from that time, he and Frederick Allen said that diabetes is a carbohydrate intolerance disease. Carbohydrate intolerance disease. That term had been lost in 1977. So who had been in diabetes field that long know that that term had been changed. And this was the biggest problem that we ever had in the history of the diabetes management. So after discovery of insulin, he was able to give his patients slightly more and more carbohydrates. So the way they treat diabetes in 1917, 1923 is called advanced carbohydrate diet. So day 1, they give them 0 carbohydrates. They test their urine for glucose. Day 2, they give them 2%. They test their urine. Day 3, they give them 5%, 6%, 10%. And when the glucose starts to appear in their urine, they say, stop. This is your maximum. Eat whatever you like from the others, but it's your carbohydrate at that level. But with insulin, they were able to go up. But interestingly, it looks like we went way up. This is the problem. We went way up. Most of the trials showed that if you cut the carbs down to around 40%, and this is data from Frank Nuttall and Mary Gannon, and you can see clearly once you reduce the carbohydrate to around 40%, you increase the protein to around 30% in comparison to 15%, the area under the curve for glucose is down by 40%. Triglycerides significantly down, more than even 40%. So we know now that carbohydrates in people with diabetes need to go down. Whether vegetarian, non-vegetarian, whatever it is, carbohydrates needs to go down. The most important is that when they reduce the carbohydrates, I can see from 60% to 40%, visceral fat went down, insulin level went down, and marked improvement in insulin sensitivity. So we lost this data in translation over time. So what happened? In 1977, the US Congress formulated a nutrition committee, politician, and they decided to increase carbohydrate for the entire nation. You can Google and you can go to 1977. And this is a time that happened, 1977. And you can see protein remained the same. And here is fat is down by 10%, carbohydrate up by 10%. And you can see obesity went way, way, way up. So in reality, we shot ourselves in our feet. And we up till now are complaining, oh, people get diabetes, are obese. You know, they are because we kept telling them eat too much carbs. This is a problem. Just for your information, fat can only make people gain weight as a lipogenic hormone in the presence of insulin. The stimulus for insulin secretion is carbs. This is what's called the bread and butter theory. So when you eat carbs, you stimulate insulin. Insulin takes the fat and put the fat in the adipose tissue by its lipogenic activity. This is the scenario. If it is visceral fat, inflammation, TNF-alpha, IL-6, BI1, MCP1, and many other problems. So in reality, Joslin Diabetes Center 2005 changed the entire dietary plan that we give to our patients. And our idea is to cut the carbs down to around 40% and cut the glycemic index down and increase the protein intake. And I will explain why we increase the protein intake. And then the fat, I have no problem with the fat. The major problem with the fat is the trans fat. We are not sure about anything else in the fat, to the limit that maybe we can argue about saturated fat. But the most interesting also in carbs, as David mentioned many, many times, no one is listening that low glycemic index is important. Actually, if you lower the glycemic index, you can see A1C is down by 0.4%. Unfortunately, in the ADA this year, poorly controlled study showing that low glycemic index increased insulin resistance. But in reality, this in non-diabetic population. You cannot take this data and put it in people with diabetes. Low glycemic index reduces postprandial blood glucose level. That's why it works. So you cannot take the data from non-diabetics and apply it in diabetes. The most interesting also is every time you increase a protein, and here is you increase a protein to 30% from 15%, even in 5 weeks, A1C is down by 0.8%. It's very important for us to understand one unique issue in diabetes. People with diabetes lose muscle mass every single year. If their diabetes is not controlled, they lose around 450 grams of the muscle mass every single year. Now, if you give them low-caloric diet, you fix the ratio around 15%, you are giving them very low absolute protein. They lose even more muscle mass. Around 25% of the weight loss is muscle mass. So to minimize that weight loss from muscle mass and to have very successful weight loss, you need to give more protein and more strength exercise. And if people have hypogonadism, you give them testosterone as well. This is why weight program worked. Weight achievement and intensive treatment program worked, was we give them more protein, more strength exercise, and that's how the results was effective. Again, you had seen this data many times. High protein, low glycemic index diet after 8% weight loss is the best diet to maintain the weight loss for longer duration. This dietary pattern is what we used in the Y-Weight program. But in reality, if you give people any diet, whatever the diet is, people will regress to eat what they used to eat, unless you give them a meal replacement that has that composition. So many companies now produce the meal replacement that have higher protein, low glycemic index, slowly digestive carbohydrates, more monounsaturated fat, and fortified with amino acids to help people with diabetes. So let me show you the early data that we have from look-ahead study. After 1 year from look-ahead study, we looked to weight loss in relation to those people using this meal replacement. And we found that people who are taking 2 per day over a year lost 11.2% in comparison to people who eat that meal replacement in lower frequency. It was very interesting and intriguing data, but we now, over time, we started to realize that those meal replacement, or I prefer to call them glycemia target specialized nutrition, actually improve glucose control, improve body weight, reduce insulin to some extent, and help weight loss. But more and more data now is telling us they can stimulate insulin, they can increase GLP-1 hormone, and I will share some of this data with you. So here is data from Professor Tati in Italy. What he did, he take group of people, 96 patients, and advise them to cut the caloric intake. If they lost more than 5% by 12 weeks, they continue. And if they lose less than 5%, they give them one glycemia target specialized nutrition, diabetes-specific formula. And then started to evaluate them. Just one. So he replaced 200 calories with 200 calories. And interestingly, here is a group that lost more than 5%, continued to lose weight, but this group didn't lose 5%. Once they got one GTSN, as you can see, more weight loss. Interestingly, the same happened with the A1C, and you can see the A1C start to drop with a difference which is significant, around 0.3%. So this is, again, very interesting. Not only that, they found that the variability in the blood glucose level is much less. Here is before, after. Variability of the blood glucose level is much less because the low glycemic index effect. Then, what is the impact? This is a whole new idea about the GLP-1 hormone. GLP-1 hormone is a satiety hormone. It also stimulates beta cell to secrete insulin, suppress glucagon production, improve diabetes. We have tons of medications now in the US, everywhere, DPP-4 inhibitor, GLP-1 analogs. So what is the impact? You know that many of the amino acids in protein actually very potent stimuli for GLP-1 hormone. You can see several of them here. So once you eat any protein that has those amino acids, you don't need the glucose stimulation, which mostly lost by the beta cell, and the protein now is stimulating the beta cell to secrete insulin in a very efficient way. Interestingly, monosaturated fatty acids and saturated fatty acids actually stimulate GLP-1 hormone more than carbohydrates. We blame the saturated fat for many, many years. I'm happy that Anthony presented very nice data about the dairy products. In our Lancet article, myself and Frank Hu and Mohan and Lee, we presented data that actually dairy products reduce significantly the risk for type 2 diabetes. But I would like just to add that my theory is also related to vitamin D. You know, vitamin D is a fat-soluble vitamin. If you skim the milk, you don't absorb the vitamin D. Even if it is written on the bottle, fortified with vitamin D. You need the fat. Not only that, saturated fat also is a potent component of nutrition that raises HDL. That's why when you look to some of the meta-analysis between saturated fat and coronary artery disease, you'll not see any big effect in at least 5 meta-analysis from 2008 up till now. So here is another study, and they give oatmeal, and they give no breakfast is in blue, and they give oatmeal, and you can see here, and then they give the meal replacement, diabetes-specific meal replacement, and you can see the blood glucose level is low, and GLP-1 hormone significantly low. It's like 4 or 5 times higher just by giving that product. So this is a last study. We presented this study in the ADA a few days ago. Again, testing 2 types of GTSN in comparison to oatmeal. Cross-sectional study has 12 male, 10 females, and we invited them for 3 different days. Each day, we give them 200 calorie oatmeal or 1 GTSN or another GTSN with different blend of amino acids to see what is the impact on glucose, insulin, GLP-1 hormone over 4 hours. And here is the results. Here is when you give oatmeal, you can see the blood glucose level up till 4 hours is high. If you give any one of those GTSN, the blood glucose level is significantly lower, significantly lower. But the most interesting, if you look to the area under the curve from the baseline, you can see here is oatmeal, and then you can see the two GTSN, one of them even can drop people to the lower glycemic level. Interestingly, one of them, which has more blend of amino acids, you can see the insulin stimulation is significantly up. This looks for me, mind that those people have diabetes for 10 years. So we're assuming that they don't have capacity to produce insulin, but they are producing significant amount of insulin just in response to this amino acids, which means that this is important part in the diabetes diet. If you look to the GLP-1, again, here is the oatmeal, and you can see with the 2 meal replacement, GLP-1 is going up. So in reality, we know now that changing dietary composition in people with diabetes, especially cutting the carbs down and increasing the protein up, which will induce satiety and will stimulate GLP-1 hormone and insulin, maybe have beneficial effect in diabetes. So in conclusion, I would like just to mention that those types of diabetes-specific formula is now integral part of the medical nutrition therapy. We are using them now in the Y-Weight program, and we use them in the look-ahead study. We use them to some extent in the diabetes prevention program, and they help people to lose a nice amount of weight. But the major issue is that if you move to natural food, you have to follow the good dietary composition in that scenario. Finally, we published all our experience in the Y-Weight program. This is a Harvard Health publication. Now translated many places, Y-Weight in many countries now across the globe. I hope to see it in Canada and in many places in Europe very soon. Before I end, I went to the heart attack grill to get the experience. They put the gown, they put the tag, they check your heart and give you that sandwich. If you can eat it, they take you with wheelchair to your car. They have ambulance by the door if you get heart attack. With this, thank you so much.
What I will do today is to review for you this topic, which I anticipate is rather controversial. And first of all, I have to disclose my conflict of interest. Actually, I have a sponsor research by one of the sponsors of this meeting, and I have several funding mainly from pharmaceutical companies. So no direct conflict of interest, and I'm an employee of the University of Milan with clinical appointments to San Donato Hospital, and I will mitigate this. I will present in the last part of today some sponsor study, but I will quote the literature before. So let's start. This is the outline of what I am going to present, and I will spend a few minutes in addressing some points that Dr. Hanley fortunately already anticipated in part, but that in my opinion are particularly important in the design and in the interpretation of any data derived from dietary. Now, we have to deal with a highly complex system, the glucose-insulin system, because, of course, glucose stimulates insulin secretion, and insulin then acts both at several sites, inhibits endogenous glucose production, and stimulates peripheral glucose disposal. This complex system can be summarized at the bottom line in two variables: the beta cell function, which doesn't mean only insulin concentration, is more complex than the simple insulin concentration, and the insulin sensitivity. So we need to know always these two variables in the interpretation of any result of any intervention. So the most used index is the so-called HOMA, homeostatic assessment index, the HOMA index, but we should remind always that this is a surrogate index, is a static measure, is not a dynamic measure. The best way to obtain, the best way match for simplicity to obtain a dynamic measure is an oral glucose tolerance test, assessing frequently both glucose and insulin. And in this way, we can build two models, basically a model for glucose metabolism, giving us the measure of insulin sensitivity, and a model for beta cell function, giving us the real secretory rate of insulin. This is a complex slide, but I wish to focus your attention on mainly on this on the liver side, because it is possible with relatively simple mathematical derivation rule out the first pass cleavage of insulin by the liver, which may be a major determinant when comparing different diets. So, and finally, still today, after almost 40 years, the golden standard to assess insulin sensitivity and insulin secretion is the euglycemic hyperinsulinemic clamp, or in the bottom panel, the hyperglycemic clamp, which allows us to dissect out the first phase from the second phase, insulin secretion. And many drug or dietary intervention or lifestyle intervention may simply modify the first phase release. So having said that, I'm going back with the publication that already quote Dr. Hanley. It's important to have in the same graph insulin secretion and insulin sensitivity. In this seminal paper, Stephen Kahn in 1993 published the hyperbolic curve where locate subject with normal glucose tolerance. So these are all normal subjects. This guy over here maintained the normal glucose tolerance with a very high insulin sensitivity and almost zero insulin. If you had measured only insulin, you would have found near zero insulin. And this woman over here maintained normal glucose tolerance, vice versa, with a very huge insulin secretion and very low insulin resistance. This is probably an obese, sedentary woman. This is probably an athlete and highly exercising individual. So that's the first concept. The second concept, very important that I want to underline, is that the position, all of us can be put in one point of this hyperbolic curve, but the position is not static, is dynamic. It can be modified with drugs, and I'll show you an example, or with dietary intervention. We published this paper in 2006 on diabetes care, where basically we studied obese, non-diabetic subjects giving for 3 months rosiglitazone. The white are the same subject before and after. You see that rosiglitazone is an insulin mimetic drug, causes a shift of the subject toward area of higher insulin sensitivity, but the insulin secretion goes down, and that's the key point. The two variables are strictly interrelated, and having said that, let me move to the second part of my talk, a concept which has already been in some way touched from previous speaker. We cannot talk of dietary intervention without considering other lifestyle parameters, mainly physical exercise. And we should also consider that hyperglycemia is almost never alone, but is associated to the other alteration, metabolic alteration of the metabolic syndrome. And it's important, in my opinion, to consider the effect of any intervention, including dietary intervention, on all the major metabolic alteration of metabolic syndrome, since the minimum common denominator is insulin resistance. So if we go back at the hyperbolic curve, we already talked today of disposition index, but basically we can divide up let's say the plan in two areas: the red area, which is the area of bad tolerance, and the green area, which is the area of good tolerance. And today is possible and is particularly relevant due to the several drugs that we have for treating type 2 diabetes and also for the different dietary intervention to be able to characterize the phenotype of the diabetic patient. And you have three examples here. A diabetic patient, with very high insulin secretion and very low insulin and highly insulin resistance. This subject 3, which in contrast has a very low insulin secretion and a very high insulin sensitivity, and that's the average subject. In any one of these patients, the aim is to move them from the red area to the green area. Physical exercise is one easy way to do that, because physical exercise is known since at least 4 decades that improve insulin sensitivity. I'm just quoting one paper for all, the paper by Boeren in 2003, where basically he studied sedentary people and athletes, and he demonstrated that athletes are in the right part of the hyperbolic curve, so high sensitivity, low insulin secretion. If you measure insulin concentration in a marathon runner, you find near 0 insulin concentration, because otherwise it would become hypoglycemic. The mechanism is a mechanism which is common to many drugs, anti-diabetic drugs. For instance, metformin is the activation by physical exercise of AMPK, and that's well known since at least 2 decades. And just a brief note on the type of fuel that we need for different exercise. I know that this afternoon there will be a very nice session specifically on this. We have basically 2 major fuels. The first fuel acts in the acute exercise, in the strength exercise, and this basically utilizes mainly carbohydrates. The second fuel is utilize all macronutrients, not only carbohydrates, and is the fuel which is used in oxidative metabolism. And of course, glucose and other carbohydrates are necessary to drive the glycolytic pathway and to produce energy in the short term. Vice versa, besides carbohydrates, also protein and fats are necessary for driving the endurance exercise. And that should be kept in mind when prescribing diets. So let's see the metabolic effects of high-carb diets. Here, as I said, the point is quite controversial. There is this very recent paper by Dr. Su, which basically assessed demonstrated an improvement of insulin sensitivity by isoenergy high-carbohydrate traditional Asian diet. You can see the protocol here. The bottom line is that the standard Western diet for 8 weeks was the comparison diet, and people kept on Asian diet end up with a higher insulin sensitivity. But in this meta-analysis, also quite recent, it was shown that other diet rather than the high-carb diet may improve glycosylated hemoglobin in type 2 diabetes. Low-carb diet versus other diet may determine a low GI, glycemic index diet compared to other diet, and also as we had today, Mediterranean diet can improve glycosylated hemoglobin, and also high protein diet. So bottom line is that many dietary approach for different reasons may result positive in improving metabolic control in type 2 diabetes. Let's go back to the Asian diet. There is an ethical difference concerning the let's say, the interrelationship between beta cell function and insulin resistance. Most Caucasian people are right in the middle of the hyperbolic curve. Afro-American people are in the area of high insulin resistance and high insulin secretion and low insulin resistance. East Asian are in the area of high insulin sensitivity and low insulin secretion. So basically, this might in part explain ethnical difference in different dietary approach. Keep in mind, always this hyperbolic curve must be kept in mind when assessing an intervention. Other example, diet with unsaturated fat partially replacing carbohydrate improve insulin sensitivity. We heard some example in the previous talk. Let me spend just a brief note on the concept of ectopic fat deposition that in my group in Milan we are actively studying. As you know, and that's something which came out in the last 20 years, besides being deposited in the adipose tissue, fat might be deposited in ectopic position, muscle, heart, and liver. And even in this case, lifestyle intervention is fundamental to determine this deposition. Fructose. We haven't discussed the issue of fructose yet, but high fructose diet is known since many years causes liver steatosis, and the mechanism are at least two mechanisms, as pointed out in this review by Joslin on diabetes. A direct mechanism where fructose is synthesizing directly triglyceride, and an indirect mechanism via the formation of uric acid, which determine inhibition of the aconitase enzyme in the mitochondrion, and an outflow of citrate, which is then converted in triglyceride. In this study, we assessed the triglyceride content in liver in patient with these are healthy volunteer which were stratified for level of physical activity. The ones who were more exercising had zero triglyceride in the liver. I'm going to skip some slides because I don't want go over time, and I'm just going to present the last 5 slides. And another concept that haven't been touched so far, the concept of different diet may induce in different ways satiety. You all know that adipocytes produce leptin, which is an anorectic hormone, and like insulin, which inhibit the appetite, vice versa, ghrelin, which is produced in fasting condition, is an anorectic hormone. And then there is the control of the cerebral cortex. We previously shown that different commercial snacks with different content in protein may induce different sense of satiety and different ghrelin inhibition. In particular, snacks with high protein content were inducing satiety for a longer period. So what we did, we actually, this was just presented in Boston at the American Diabetes Association. We went on and we studied breakfast with different protein, lipid, and carbohydrate content, high carb versus low carb, and we look at the glucose, insulin, and ghrelin as an example of satiety hormone. But we look also at evoked potential. We looked also at the capacity of different nutrients in activate attention at the cerebral level. These are the different breakfast composition. We studied 20 healthy volunteers, studied four times, and glucose, 50 grams of glucose was the control. And then the 3 breakfasts, you can read the first one, B1, was mainly carbohydrate. The second and the third one were containing high protein, high fat. This is the nutrient composition. No difference in the area under the curve for glucose concentration. A slight tendency to a lower insulin not statistically significant in the high protein breakfast. A tendency very close to statistical significant for ghrelin inhibition in the high protein, high fat breakfast. And the most interesting part, I'm sorry, let's say this number are after 3 hours from the breakfast, this measurement, is the appearance of the P300 wave in the evoked potential, which directly correlates to cognitive function and attention, which the breakfast with the higher content in protein and lipids was activating much more earlier, indicating better attention. I'm concluding. So regarding the breakfast study, our data show that commercial breakfasts were able to elicit lower glycemic and insulinemic responses, notwithstanding a higher carbohydrate content, up to 3 hours after consumption of the meal. All groups receiving breakfast had a tendency to maintain higher satiety after 3 hours with respect to the sugar alone, via ghrelin inhibition. The breakfast containing the combination of hazelnut and chocolate cause a better cognitive performance, statistically significant, with respect to the other groups after 3 hours. The conclusion of the talk is that diabetic patients may benefit of low-carb diets as concern a lower glycemic index, higher insulin sensitivity, lower insulin levels. High-carb diets may be effective in actively exercised diabetic patients, provided that appropriate treatment and nutritional counseling. I hadn't time to discuss the carbohydrate count, for instance, is provided. The quality and quantity of carbohydrates as well as of the other macronutrients is relevant for both physical and cognitive performance. Thank you. Sorry.
I'll be presenting the results of a systematic review and meta-analysis of randomized controlled trials that investigated the effect of tree nuts on glycemic control. So this is just disclosure of commercial support. So the project was funded by organizations listed in the program. And also I have been funded by CIHR and BBDC. I have no relationships with commercial interests, and none of the sponsors had a role in any aspect of the present study. So just to give a bit of background, so as we all may know, that cardiovascular disease is the leading cause of death globally, and that's shown in this figure from the World Health Organization, showing that the 10 leading causes of death in the world, and showing the 10 leading causes of death in the world in the year 2012. Cardiovascular disease has also been shown to be a major cause of death in individuals with diabetes, and so these are two figures that were adapted from a study by Hafner et al. That was published in the New England Journal of Medicine just over a decade ago, showing that in comparison to people without diabetes, people with diabetes have a higher incidence of heart attacks, and following after the first year of a heart attack, they have a higher mortality rate. Tree nuts have also been shown to be inversely associated with cardiometabolic risk. So just in the last year alone, there have been 4 systematic reviews and meta-analyses of prospective cohorts that have been published, which have shown that tree nuts are inversely associated with cardiovascular disease, diabetes, and all-cause mortality. Tree nuts have also been recognized for their health benefits. So there have been 2 qualified health claims granted by the FDA that have been based primarily on their LDL cholesterol lowering effect. They've also been included in heart association guidelines, such as the American Heart Association and the Canadian Cardiovascular Society for the management and prevention of diabetes. But the question is are there benefits of tree nuts beyond the LDL cholesterol lowering benefit or effect? So when we look at tree nuts in the Diabetes Association guidelines, there are no specific recommendations for tree nuts alone. In the Canadian Diabetes Association guidelines and the American Diabetes Association guidelines, they recommend dietary patterns that include tree nuts, but like I said, no specific recommendations of tree nuts alone. And in the European Association for the Study of Diabetes, they only mention them in a comment on that they have high antioxidants and that this may be protective against cardiovascular disease. So some of our work has tried to address this, and so just in the last year, we've published 2 systematic reviews and meta-analyses of randomized controlled trials. The first one looking at the effect of tree nuts on glycemic control, specifically in individuals with diabetes. We showed a significant lowering in hemoglobin A1C and fasting glucose. And the second meta-analysis looked at the effect of tree nuts on metabolic syndrome criteria. And in this meta-analysis, we showed that there was a significant lowering in triglycerides and fasting glucose. So this led to the rationale of the current project, which was to synthesize the evidence on which recommendations are based for the metabolic benefits of tree nuts beyond LDL cholesterol lowering, specifically on glycemic control outcomes in all comers. So to expand on the first meta-analysis that I touched on, and so not just to focus on individuals with diabetes, but with other health statuses. So just to get into the methods, so just to restate this, the objective is to pool the effect of tree nuts on glycemic control from randomized controlled trials in all comers, and this project was part of a larger project that looked at other cardiometabolic endpoints. We followed the Cochrane Handbook for Systematic Reviews of Interventions, and reporting followed the PRISMA guidelines. We searched 4 different databases as well as manual searches. We registered our study on clinicaltrials.gov, and our search terms followed the PICO framework. We were interested in 4 main outcomes, so hemoglobin A1C, fasting glucose, fasting insulin, and HOMA-IR. And these are the eligibility criteria. So for a study to be included in our meta-analysis, it had to be a randomized controlled trial conducted in humans with a follow-up duration greater than or equal to 3 weeks. There had to be a tree nut intervention in the treatment arm, and there had to be an isocaloric comparison between the treatment and the control arm, and they had to report outcome data on at least one of the 4 outcomes that I listed above. So once we've identified studies from our database search, we look through them first based on title and abstract. If they don't meet our eligibility criteria, we exclude them. And the remaining studies undergo full article review. And then again, if they don't meet our eligibility criteria, we exclude them, which leads us with the final studies to be included in the meta-analysis. So once we have these final studies, we start extracting the data using something called a proforma. And we have 2 independent reviewers that extract data on the following. And the 2 independent reviewers also assess the study quality using the Halen methodological quality score. And they also assess the risk of bias using the Cochrane collaboration tool for assessing risk of bias. And then lastly, for our statistical analyses, for our primary pooled analyses, we use a generic inverse variance method using random effects models. Our heterogeneity analyses, the significance is tested by Cochrane skew and quantified by I-squared, and all of these are done on Review Manager. And then in order to explore sources of heterogeneity, we conducted a priori subgroup analyses on the following subgroups listed here. And we also conducted publication bias analyses using visual inspection of funnel plots as well as Eggers-Inbex tests. And all of these are conducted on Stata software. So to get to the results, so we identified more than 1,700 reports, and after reviewing title and abstract, we excluded majority of those. And that left us with 88 reports that were reviewed in full, 2/3 of which were excluded, which left us with 32 trials included in the final meta-analysis. These are just some of the trial characteristics. So we had over 1,600 participants. They were middle-aged. 44% were obese. Most of them had metabolic syndrome criteria or diabetes. More than half were less than 12 weeks duration. Majority were considered to be of poor study quality based on the Halen methodological quality score. And the median net intake was around 52 grams per day. So to get to the primary analyses. So this is our forest plot for hemoglobin A1C. We found a non-significant reduction in hemoglobin A1C with significant heterogeneity. For fasting glucose, we found a significant reduction with significant heterogeneity. For fasting insulin, similarly, we found significant reduction with significant heterogeneity. And then lastly, for HOMA-IR, similar findings, significant reduction with significant heterogeneity. So in terms of our subgroups, I'm only going to be presenting the significant ones, and I'm going to go through them fairly quickly for the purposes of time. So these were our subgroup analyses for hemoglobin A1C. We found significant effect modification for baseline hemoglobin A1C, as well as for absolute fiber intake, and additional subgroup analyses confirmed the significant effect modification by baseline hemoglobin A1C levels. For subgroup analyses for fasting glucose, we found a significant effect modification for follow-up duration. We didn't find anything for fasting insulin. So for our subgroup analyses for HOMA-IR, we found significant effect modification for follow-up duration as well as study quality. And further subgroup analyses showed a significant effect modification for absolute fiber intake. So next to the discussion, so some of the limitations of this meta-analysis. So majority of the trials were considered to be of poor study quality according to the Halen methodological quality score. More than half were of short duration. There's evidence of moderate between study heterogeneity in the overall primary analyses for fasting insulin, which were not explained by any of the a priori subgroup analyses. There was evidence of publication bias in the pooled analyses for fasting insulin and HOMA-IR, which I did not show for the purposes of time. And a portion of the trials did not focus on glycemic control endpoints as a primary outcome. So just to summarize and conclude, so pooled analyses of 32 trials show that a median tree nut intake of 52 grams per day over a median duration of 9 weeks significantly reduces fasting glucose, fasting insulin, and HOMA-IR in all comers. Although significant lowering was not seen for hemoglobin A1C, the direction of the effect favored tree nuts. Subgroup analyses suggest that the greatest benefits were seen in terms of hemoglobin A1C for individuals who had baseline hemoglobin A1C levels greater than 7% and absolute fiber intakes that were greater than 25 grams per day. For fasting insulin, for those trials that had a longer follow-up duration, and for HOMA-IR, again, trials that had a longer follow-up duration and higher study quality, and for some reason, lower absolute fiber intake. But I didn't go through these results in detail for the purposes of time. And lastly, based on the limitations, there is need for longer, larger, higher quality trials. And that concludes my presentation. I'd just like to acknowledge my lab members. Thank you.
Tony, I had a question for you about the heterogeneity of some of the results on the dairy intake on your clinical trials. I wondered whether they had looked at whether the supplementing dairy in people who had less than 2 servings a day compared to those who had more, because my understanding in weight loss was that if you didn't have enough milk and you did sufficient, it worked. But if you had too much, it didn't work.
So I can't recall the details of that meta exactly, but I think the take-home message on trials of dairy to date is that we've got an enormous mix of design issues, including what you've referred to in terms of baseline dairy, how much what kind of a separation we're getting, the forms of dairy, duration, what kind of outcomes, where the dairy is coming from, which I think is potentially important given some of the changes in macro and micronutrient profile. The fatty acid profile I showed was actually from New Zealand, which may not represent what we're seeing in fatty acid profile from other parts of the world. So the short answer is I don't have a clear answer for you.
Yeah, I'm Patient Sobi from College of Pharmacy, Xavier University, New Orleans, USA. This is addressed to 3 nuts. Just wanted to know whether you used a combination of nuts, or are all the nuts producing the same metabolic effect on glucose?
So the studies in the meta-analysis, there was different trials using different types of nuts. When we did our subgroup analyses, we didn't see any significant differences between trials that use, say, like almonds or hazelnuts or walnuts. So no, I wouldn't say there's a specific tree nut that showed this effect.
So what advice do you give to people who have sensitivity to nuts?
Well, I wouldn't advise that they eat tree nuts. There's many other ways that they can modify their diet to control their glycemia. So I wouldn't, if they have sensitivity or allergies to nuts, I wouldn't recommend for them to eat tree nuts. But for those that can, it's one way that they can modify their diet.
Okay, thank you. David Jenkins.
Tony, in view of Osama's very impressive results with meal replacement, and one's looking then at sort of milk drinks, one's looking at protein drinks in many ways. Do you think that we would get the same sort of effects with other protein drinks, for example, soy drinks or whatever, that may have a low glycemic index and high protein content?
You know, as long as you increase protein intake, you will get benefits on thermogenesis, on satiety, on stimulation in general of insulin and GLP-1. But the most interesting is that if you modify the amino acids in a way that you know that it will stimulate more insulin and more GLP-1, it will be even better. So people who cannot get those meal replacement, definitely they can go with protein supplement. As long as the carbs in them is not sugar and low glycemic index. What those meal replacement added is that they added more fiber, modified maltodextrin, slowly absorbed. There is data now to show that maybe fermentation that occur in the terminal ileum and the colon is also stimulating the GLP-1 hormone. The other part is that, of course, it will be fortified with monounsaturated fatty acids more than one you can get from protein drink.
Yes, a question. First that one, and then you.
Thank you, Jenny Brand-Miller, University of Sydney. The message I'm taking away from the 2 sessions this morning is that if you take the typical control diet and you take something out and replace it with many different things, they can be olive oil, or they can be nuts or dairy foods, or even high protein hazelnut cream pies. So my question is, what is exactly wrong with the control diet? What are you taking out when you replace those calories? So one of the ways we might address that question is actually to pool all the data, pool the characteristics of the subjects and the diets, and see what it is about the control diet. And my guess is it's something to do with the carbohydrates.
You raised the very important points, and many of you had been on the ADA. There is one presentation which actually impressed me very, very nicely, although the data needs some clarification. Looking to when you give any diet, over time people regress to eat what they used to eat. So whatever you give them, higher protein, lower carb, higher fat, lower fat, they will eat back the same, and the regression will be quite changed. So this is a behavior component, and this is a problem with the early diet or early study that was done by Frank Sachs. He gave different composition and claimed that there is no difference between them. But the reality is that people, by the end of the study, are eating exactly the same. No difference between them. That's why it looks like the best way is to go to what people usually eat. And that's what we did in the Y-Weight. We formulated 17 menus from what people eat every single day. And then we changed the composition to increase what they eat from protein a little bit up, reduce the carbohydrates a little bit down, and modify slightly the salt and sugar and trans fat and so on. But it is the same meal. So from their visual part, it is the same meal. And actually it worked very well. The compliance is very, very good. If you give people a very strict diet, vegan diet, Atkins diet, Ornish diet, whatever, they will do it for a few weeks. But beyond those, they will not continue to do it.
Thank you.
Sorry, I just wanted to add on. There's a meta-analysis that I discussed that was looking at the effect of tree nuts specifically in individuals with diabetes. And so the largest trials in that meta-analysis actually used tree nuts to displace carbohydrates. So I just wanted to mention that since that's what you were asking about.
Okay, now we have a question here, then we have time for one more question, I think.
Thank you. I'm Sarah Madavi from Toronto. My question is for Dr. Hamdy, who is sitting right beside Dr. Hanley. Very interesting and entertaining presentation. Thank you so much. As I was listening to your presentation, I couldn't help it but wonder what your recommendations would be for people who have diabetes and chronic kidney disease with regards to the protein portions that you're recommending. So if you could address that. Thank you.
Yeah. This is a big issue. You know, we had been living in a myth for years around protein. And in 2008, I think if you attended the ADA in 2008, we have a big debate. And I was debating the guy who implemented the whole concept of low protein. In reality, if you cut the protein way down, first of all, you will not save the kidney. There is no change in GFR. Big trial from all nephrologists, MDRD study, didn't show any benefit. In reality, every time you cut the protein significantly down, even you go to 0.6 gram per kilogram, which is intolerable diet, those people get severe protein malnutrition, they lose muscle mass, they have hypoalbuminemia, they have edema, and when they go for dialysis, the mortality is significantly up. And that's why that whole concept is obsolete. In reality, many of the data, if you look to the Nurses' Health Study, the comparison between the first quartile and highest quartile of protein intake actually have the lowest ischemic heart disease. So it is the source of protein. We know that processed meat and meat may not be the best source of protein, but there are many very good sources of protein. I don't think that for renal, you have to reduce the protein to any level. In reality, the kidney has very good capacity to compensate.
Sorry, just a really quick follow-up question. So you're telling me that with nearing end-stage kidney disease, stage 3, stage 4, that we would not reduce protein at all?
Quickly, there is a study done in California showed that you can postpone dialysis for only 6 months.
Okay. Do we need to close the session, or can we have? Okay, one short more question, because we're running out with time for lunch. Yeah, one short here.
Thank you for nice presentations. Ingrid Løvold-Mostad from Trondheim University Hospital in Norway. I have a question for Ursula. It was about the incidence of type 2 diabetes, I think, regarding the omega-3 fatty acid intake from supplements versus fat fish. And my question is if the amount was the same, because I was wondering maybe the amount was a bit bigger from the supplements.
That's a good point, and by eating fish, it's very difficult to achieve those amounts that you easily get by taking supplements. For example, by using supplements, it's very easy to get 1 gram per day of EPA plus DHA, but eating 3 fish meals per week, of which 1 to 2 are fatty fish, you get roughly 250 milligrams per day. So that might be one issue. But there's a clear trend that if you use fish or supplements, then it might not be that good for type 2 diabetes. But if you use fish, there's no evidence that it's harmful for you.
Okay, thank you. I think we need to. Sorry, I know myself have a lot of questions I would like to put in everyone, but we need to stop here.